Thank you, Indu. Thank you very much for organizers for having me here. And I was asked to talk about AMDS of FET in the acute aortic dissection, about indication controversies. What's the evidence? Okay. Well, I'll try my best. These are my disclosure. Right. Like I said before in that previous session, the commonest type of repair in a type aortic dissection in the interposition graft, which is still ongoing for many, many years, hasn't changed much. And then we've seen the kind of the last mention about this intervention in the last decade and in the UK. And then not a lot of changes happen, and the majority of them be interposition graft. There's only very, very small percentage of patients who have an aortic arch intervention, and then probably about 20% of root. Why? Because from 2008 to 2012, when we look at it, average number of aortic dissection, or aortic surgery, not dissection, performed by a general cardiac surgeons, 2 cases per year. So that 2 cases could be aortic dissection, or it could be ascending, or it could be root, or a combination of both. So when you have acute dissection at nighttime, midnight, why do you want to start doing something more complex? Understandable. But we can't move forward like that. And I've shown that picture before. We all like to see that from time to time we see when we do the hemi-arch, beautiful construction or beautiful remodeling of the arch and the descending. It is exception rather than norm. We all know that. But once in a while we're seeing one of those, we think, oh, we don't need to do anything else, just do interposition, that will be fine. But that's not the case. This is what we see most of the time. And then many of you have seen these before as well, kind of arch, proximal descending thoracic aorta expand, aortic root that left behind expand, and then horrible to treat. Natural history of type A dissection after surgery is if your labor mortality is over 70 years old, when patients have a false lumen patent, that the survival is low. And then if you also look at the patients over 45, their freedom from reoperation in about first 5 to 10 years, very, very kind of low, because quite a lot of people end up having the second operation, sometimes third operation. And so we need to start thinking. Many years ago, I used to say regularly, just do interposition graft, do what you can, and then afterwards, we'll deal with it, refer to the complex centers. But 15 years later, we should still be doing the same thing? Should we be consider more suitable, more durable, a little bit more extensive solution that might reduce the risk of problems? And then one thing is nowadays we need to have a uniform classification and entry and also re-entry tear directive repair, because everybody who's doing the performing aortic dissection surgery should be assessing the patient where the entry tear and where are the re-entry tears. And based on that, you can actually direct the kind of tear rather than just purely just doing. I still know some part of the country still having some people clamping and doing the anastomosis without circ arrest. I think 2024, it is. Okay, you might get away with it from time to time. Probably not, it doesn't serve the patient. And then uncovered stent, we've seen it before with the John Bodis kind of stent, and then which was failed at the time because it was a balloon stent, the expandable stainless steel stent. Now, my talk is about AMDS and frozen elephant trunk. So this is AMDS, single piece device, PTSD felt kind of colored. One thing is, if you twist it, the whole thing will bend. If you squeeze it, it elongates. If you let go, it will shorten. And it does exactly the same inside of the aorta as well. So remember that. It is important to know that. And then this, the idea about distal anastomosis and cause UNT tear, DANE. a new entry tear, that kind of causes a persistent the distal kind of the false lumen, the patency. That's not necessarily, not because of kind of there's no stent. If you don't have a kind of the good enough Teflon sandwich or any sandwich that you do, if you miss the layers, you will create this kind of tear. Even with the AMDS, you can still produce Dane. So something that we need to think about. And the distal end of the stent, even though it is supposed to be kind of to avoid the design, very often when you're introducing, it doesn't stay like that. So if you don't know where there's a re-entry tear, you can actually push through into the re-entry tear into the false lumen. So you need to make sure that you assess the aorta properly. And then there's a 4 kind of device with 2 sizes, taper and straight, and the sizing is fine. Still, we only have a kind of 2 sizes, and the 4 kind of 2 designs. So I think we need to have more design available. And then it says introducing these are very easy to deploy. And the idea is very good. Once you enter into true lumen, deploy it, true lumen expand, false lumen compress, depressurize. But making sure that that's not the only thing. Let's talk a little bit about proximal elephant trunk. This has been in for 20 years now. And it's nothing new now. So the whole kind of world had the 4 devices. You've seen the kind of FET open plus and neo. And then with a variety of sizes now with so many different kind of the pattern. And then with Thoraflex hybrid, with the kind of 2 versions. And now we even got the TX version now with the kind of the Marcos Janos, so we can do that. So think about indication. To me, AMDS for DeBakey type 1 dissection with malperfusion or without malperfusion. Because it was initially designed and saved for treatment of malperfusion to expand true lumen. But patient without malperfusion, because of expansion of true lumen, and that allows the kind of remodeling, positive remodeling. That's the reason why I'm putting it as a without malperfusion. And the FET, still DeBakey type 1, or entry or re-entry tear in the arch or proximal descending thoracic aorta, with malperfusion with narrow true lumen, and retrograde type A dissection. And the complicated type B, that's not suitable for TIVA. I think for me, these are the indication for frozen elephant trunk. AMDS is that. I put it in the red color for the AMDS. This is not designed for patient with a tear in the arch. If you put your AMDS across the arch, when there's a re-entry tear there, the true lumen flow into the false lumen, it will expand, and then you will have a kind of early problems. And also, it also applies for the proximal DCA. Even down to mid-DTA, if you have a re-entry tear, I would not suggest that you should put the kind of AMDS into that kind of patient, unless you have no other kind of choice. Also, be careful with Gothic arch, because AMDS is a single device. Like I said it before earlier, you can bend it easily. So even Gothic arch, if you put it larger device and bend it, it just collapses in the middle. And they will become a kind of if you lose the M+, all these the ASD closure device into aorta, exactly the same. The kind of all the wire meshing will be like a kind of layer cover sitting in the middle of the aorta with the bend. So we don't know how this patient will behave. There are some of those appearing in the kind of some of the European series. So now if you have a kind of sizing, getting closer between the 2 sizes, either size is suitable, I'll go for the lower size or the smaller size rather than bigger size in the Gothic arch or in the too much tension in the front. Controversy. I said Dane prevention, and I'm not so sure about the Dane prevention. Dane prevention have to be your surgical technique to make sure that reinforce and then the 2-layer sandwiching is important. Remodeling, some people don't believe in it, and I have seen enough to see that there are clearly some remodeling kind of evidence for AMDS, as well as frozen elephant trunk. The use of AMDS in presence of re-entry tear, some people say it doesn't matter. and I do think it matters. And the management of persistent false lumen after the AMDS is something that it is not easy to manage, and that will require the more complex management for these patients. And the use of FET and the risk of spinal cord injury. In my experience from the spinal cord injury in the acute aortic dissection, if you use 10 centimeter stent, frozen, the risk is pretty low. But if you go for 15 centimeter, if you can't keep the blood pressure high post-op because of vasoplegia and other reason, then the risk is slightly higher. So I think these are the kind of area controversial. People continue to debate and argue about it, but I think we need we're starting to see clearer picture of that with our experience. Evidence. When we first started the AMDS, the first one came from Dr. Aung from Edmonton. So with this patient population with good remodeling data, a reasonable outcome with the malperfusion, 50% of patients with malperfusion. Implantation time saying 2.1 minutes, which is essentially when you deploy the stent. That doesn't actually mean that the circulatory rest time is 2.1 minutes. Actually, circle rest time still is as long as between 30 to 40 minutes, 45 minutes. And so we had to prepare the kind of arch. But it's a decent data, and to start with. And then there's data from Germany showing that even patients with a kind of occluded arch supraaortic branches after AMDS, true lumen open up, you restore the kind of patency of these branches. And that's led to the kind of some of those evidence led to further expansion or use. But these centers now seeing that some of those are the issue now as well. So I think it is still early to yet. And I've shown that kind of during the lunchtime about 3 years outcome of the AMDS, about Dr. Aung's kind of group, which you can see the 46 patients. And then where you can see the kind of malperfusion was 56.5%, so pretty kind of high percentage of the patients. And then when you look at the median circle rest time is 33.5 minutes. So it is not very short kind of circle rest time, but 30 minutes, we all feel comfortable to do whatever kind of arch procedure we're happy, so which is fine. And so you need to make sure that your cerebral protection strategy and cannulation and the things are prepared towards AMDS. And I don't fancy putting the kind of cannula poking through the AMDS into the branches where it already cannot involve in the tears. And the mortality, 13%, 30-day mortality, 2 years mortality is 19, and then 3 years, 21.7 is a fairly decent mortality. They kind of quite comparable, so in 3 years data. And then there was 0 days in this patient group, and the disease-related reintervention, 13%, but there was no device-related reintervention. And so it is kind of quite interesting to see that data. This is just to remind ourselves about the kind of the aortic zones. So when you look at the aortic zone, zone 0, and there's kind of the partial thrombosis at the kind of at the time of discharge, and then there's a complete thrombosis, and then coming at the kind of the discharge, and they gradually increase by 3 years. And so you can see the remodeling data is there to see that it's improved remodeling with the AMDS. But one thing I'm still not quite sure about is why you still have some of the patients with a patent false lumen at zone 0, which is essentially proximal arch distal ascending area, where it just immediately distal to the anastomosis. So we need to be cautious and then watch closely what happened to these. Then we go to the kind of US data with 30 days results of ID persevere trial. And then this is mainly for the patient with the clinical malperfusion, 80%, and then number of patients with radiographic malperfusions, 20%. And there's a pre-op kind of the malperfusion status, as you can see. And then when you see that there's a 10% of patients have a guide wire use, and the fluoroscopy use is about 8%, and the 84% have a concomitant procedure. And then you can see that AMDS, the implant time is quite short, hypothermic circulatory arrest time quite short, and then hospital stay is not too bad. And you can see that compared to hemi-arch reference cohort, the mortality is lower, and then stroke rate is lower, and the MACE is lower, and the renal failure rate is marginally lower. And so it is for malperfusion patient group, it is reasonable to use, provided that your indications and that your techniques right. Technical success is 98%, and then you can see the rest is self-explanatory. So that's how they concluded, but we need to watch with longer-term data. This is only 30 days data yet. And we have a UK data on the FET in acute aortic dissection with thoraflex hybrid. I've shown you before. The majority of people see that before. And I still notice that about 18% of patients still have a femoral cannulation. And I think probably that might be changing over the next probably about 5 years, hopefully. And then the stent length is 10 centimeter and 15 centimeter, 50-50. And then stent site majority is around 30 millimeter stent. And you can see that the cerebral circulatory arrest time is 63.6 minutes for frozen elephant trunk. And the bypass time 339 minutes. And then these are kind of concomitant repair route, and the aortic valve repair and the distal aortic perfusions, T-valve. And the mortality 13.6%, and the stroke rate at 13.6%, and the 1.8% paraplegia. So this is a pretty kind of decent kind of result for the kind of group. And you can see that post-op, pre-discharge, 6 months and 1 year, forced lumen thrombosis rate is very promising. And when you look at the kind of follow-up, the remodeling data, and that segment was the same, that kind of similar to most of the studies show that segment A and segment B have a positive remodeling, but less so on the segment C. So this is one of those patients, acute type A aortic dissection, limited type B, they are descending involvement. In young patients, these are reasonable patients to do frozen elephant trunk, and kind of very good result. These are very early, around 2009, 2010 kind of operation. You can do it on the zone 2 FET with extra anatomical kind of bypass. And that should be kind of reasonable kind of operation for people who do routine kind of frozen elephant trunk procedure as elective. One thing for sure is we need to assess the downstream aorta carefully. I've been showing that so many kind of ambuscope to the angioscope picture, but I'm just pulling back and to show you something else different. We have TOE every patient. We need to look at TOE. Don't just leave it for anesthetist. You need to stand there with anesthetist. Look at it. This patient got this. You see, the kind of flap is dynamic occlusion of this vessel. Very obvious. Look at this one. It's very, very narrow. It's a celiac, and the kind of partly kind of supply from the true lumen, partly supply from false lumen. And then you can correlate that one with the CT scan if you look at it carefully. So if you look at CTs carefully, look at the TOE carefully, and then you can then plan the operation you can predict. And this is a 53 years old man, type A dissection with visceral malperfusion because he presented with abdominal pain, so it was a delayed diagnosis by 5 days. And came with this CT scan. So he's not doing the AMDS. Because one good thing with AMDS, you can get all the way down to near the diaphragm, so open the true lumen wider compared to frozen elephant trunk. This one I intentionally knowing doing that because I thought that the SMA need to salvage. This is an AMDS for type 1 zone 0 AMDS. You can see the very nice the remodeling. This is a pre-discharge CT scan about 4 or 5 days after kind of surgery. So you can have a very decent remodeling with AMDS as well. And as you can do it on the zone 1. And then you can do it in the zone 2, AMDS. And then this is a patient who presented with no blood flow to the legs and very narrow true lumen and ended up with occluded the infrarenal. And patient blood pressure in the leg was 20 bilaterally. So I need to do the axillobifemoral bypass first and then followed by the pericardial pleural effusion drainage and followed by surgery. End up putting AMDS. Unfortunately, sometimes these are useful. So conclusion, there's a growing evidence the benefit of AMDS as well as FET available. We need long-term real-world data that will provide the evidence-based decision-making in the use of these devices to drive the change in practice for our patients. And the AMDS FET will be a complementary devices for the management of aortic dissection rather than competition. Thank you very much.